Hi everyone, in this recording, continuing on with digestive disorders, I'm going to talk about ulcers, inflammation, and obstructions that can occur within the digestive system. Quick reminder of the layers of the digestive tract. Here we have what would be the lumen where food passes through and is going to be ultimately broken down and prepared for absorption. When we look from the most inner level of the lumen, we have the mucosa, and we can see that inner layer here. And within the mucosa, we can see lots of different glands that are present and ducts that are going to be very important for digestion. Mucous neck cells, chief cells, parietal cells, endocrine cells, and G cells. And we'll talk about what can happen when these cells are not functioning properly because of some sort of disorder. We also have the muscularis mucosa. This really just helps propel nutrients in this direction. Beneath that, we have the submucosa where we have lots of blood vessels. There's also lymphatic vessels and nerves. Then we have the tunica muscularis. This is what's going to be permitting contractions and motility. So it's smooth muscle that allows for the process of, if you remember the term segmentation and peristalsis. And then we have the outer layer, the serosa, which we can also see here. And this is going to be a layer that is continuous with other serous membranes of other structures in our body. As a reminder, the stomach is this hollow muscular organ that's located just below your diaphragm. And remember, it has both mechanical and chemical digestive functions. The mechanical being your churning and your mixing, and then the chemical digestion involving the release of various different chemicals, including from these glands, that are going to secrete substances that are going to contribute to your ability to digest and absorb nutrients. So this can be anything from mucus to digestive enzymes to hormones. Now, within the mucosal layer of the stomach, we have what are called gastric pits. So this would be the lumen here again. Here's your mucosa. We have these pits within the mucosa. And so gastric means stomach, so they get the name gastric pits. And the gastric pits, these depressions within this epithelial lining, are going to, toward the bottom of them, contain gastric glands. So we move into the pit and we can see all these cells here. I'll zoom in for a moment so you can see it a little bit clearer. You can see what you would recognize as being cells. And so these are glands that are made up of cells, and they're going to be producing very specific substances depending on which gland we're referring to. So for example, the parietal cells shown here, these are going to be secreting an acid, but more specifically what's called hydrochloric acid. Hydrochloric acid is going to be formed when the hydrogen and the chloride that make up hydrochloric acid are going to travel to the lumen of the stomach, where together they will form hydrochloric acid. And hydrochloric acid in the stomach is going to be working to dissolve the fibers that make up food. It's going to break down or denature protein. It's also, because it's acidic, going to inactivate bacteria, but also inactivate other pathogens as well. You might remember from normal anatomy and physiology that pepsinogen is a proenzyme. And when it is in an acidic environment, which is created by hydrochloric acid, it will convert into its active form, which is pepsin. And pepsin is an enzyme that is going to be specifically breaking down proteins. Parietal cells also produce intrinsic factor. Intrinsic factor is necessary for the intestinal absorption of vitamin B12, and we need B12 in order to produce proper red blood cells. When we consume B12 orally and it reaches the stomach, its goal would be to reach the small intestine where we can absorb it and then use it as part of the process of making red blood cells. But in particular, because of the very acidic environment of our stomach, B12 would not be able to make its way on its own to the small intestine. So enter intrinsic factor. It sort of acts like a bodyguard, carrying B12 throughout this rather rough environment throughout our stomach, both mechanically and chemically, kind of protecting it until it gets to the small intestine where it can be absorbed. Chief cells are what produce pepsinogen, which we know that pepsinogen in an acidic environment will convert to pepsin, that enzyme that breaks down proteins. Chief cells, these are also going to produce lipase, and lipase is an enzyme, lip referring to lipid, and the ase referring to an enzyme. Lipase will hydrolyze lipids into fatty acids and glycerol, so it'll break down lipids into their smaller components. Mucous neck cells, as the name suggests, these are going to be producing mucus in order to protect the lining of your stomach against really the corrosive nature of gastric acid. And they're called mucous neck cells because they're found really in the neck part of the gastric pits. So we require these cells in our stomach to be present and functioning properly, and there are disorders that can impact their function, as we'll learn. Yet another reminder about the pH scale. The lower the number, the more acidic. The higher the number, the more basic or the more alkaline, with neutral remaining here at 7. And remember too that the more acidic a solution, the more hydrogen ions are going to be present within that solution. So we have higher number of hydrogen ions here, and then they reduce in quantity as the solution becomes more basic. What I want to mention from this slide before we move on is talking about the stomach. The normal pH of your stomach when there isn't any food within it is going to be around 5, between 5 and 6. Now, after you have a meal and different secretions have occurred, the pH reduces to anywhere between 1 and 4. So in other words, we know the stomach is going to be an acidic environment, but it becomes more acidic when food is present. Our stomach needs its own defense mechanism in order to prevent it from injury. And when this fails, then injury prevails. Both acid so hydrochloric acid and pepsin are actually very dangerous to our stomach lining, which is ironic because they're produced by the stomach. So if the hydrochloric acid and pepsin come into contact with the stomach lining, it could start to actually digest the stomach. And so the gastric mucosa that is present, the mucus lining produced by those mucus cells, is going to protect the stomach lining from acid and pepsin by just really producing this coat of mucus that we call the mucosal barrier. So this mucosal barrier is going to consist of mucus, of course, but it's also going to consist of bicarbonate. The mucus and the bicarbonate secretions have this really buffering action against the acidic nature of the substances, hydrochloric acid and pepsin, ultimately protecting the gastric lining. I'm going to get a little bit more specific now on this topic of the mucosal barrier. The mucosal barrier is made up of these tight junctions. This is where cells are held tightly together. The epithelial cells, that is. There's also growth factors that are present, which will work to inhibit any excess gastric secretion. And then there's membrane transport systems as well that can remove excess ions. In other words, preventing hydrogen from diffusing into the mucosa, because we know hydrogen ions are acidic. So if we have too much there, it's going to damage our sensitive mucosa. So all of these factors are going to contribute to making the gastric mucosa relatively impermeable to acid. The mucous membrane also has rapid blood flow, and this rapid blood flow is going to provide all the nutrients and oxygen that it needs for survival, but it also helps remove any excess hydrogen ions that, if they accumulate, can make the stomach too acidic. What we can see in this image here is that this is a parietal cell, and we have chloride and hydrogen that will be brought into the gastric lumen to form the hydrochloric acid that we need for normal functions, but we also need to make sure that it doesn't accumulate too much and make the stomach too acidic. Of interesting note, the blood supply is so abundant within the stomach that, in other words, there's so many branches off of the celiac artery that supply the stomach that nearly all arterial vessels have to be occluded before you'll actually start seeing ischemic changes occurring within the stomach. So what happens when our stomach's defense mechanisms fail? Well, one example is called gastritis. Gastra referring to stomach, itis is inflammation, so this is an inflammatory disorder of the stomach. And we'll learn shortly that it can be an acute state of gastritis or a chronic state. The digestive layer that is involved, and this is important that you know this, is the mucosal layer. The function of this layer, as we know, is going to be to secrete enzymes and mucus. We talked about all the different glands, or we've talked about some of the different glands that are involved or incorporated into this mucosal layer. We know that the stomach itself does not absorb much compared to the small intestine, but it does absorb some water, ions, some alcohol, and drugs are absorbed at the level of the stomach. Now, when we experience an imbalance between the production of acid and the secretion of mucus, so more acid than we have mucus, it can lead to gastritis, and this can lead to the formation of ulcers. There is a strong relationship between a bacteria called H. pylori, which stands for Helicobacter pylori, and the development of gastritis as well as ulcers. And not just ulcers of the stomach, but ulcers of the digestive tract. Helicobacter pylori is a type of gram-negative bacteria. These bacteria can enter your body and live in your digestive tract, and after many years, they can really start attacking the mucosal lining, which just leads to inflammation. This can lead to the development of ulcers. We'll look closer at this later. And in some cases, especially if it's not treated and somebody is suffering from chronic inflammation and chronic ulcers, they could develop gastric cancer. Infection with H. pylori is actually very common. About 2/3 of the world's population have H. pylori in their body. And for most people, it doesn't even cause any inflammation or ulcers or other symptoms. More specifically, though, we're looking at about 70% of cases are people that have a persistent infection that's asymptomatic, meaning they don't have any symptoms of infection. In other cases, people can have symptoms, and it can be treated with medication to help kill this bacteria and help the stomach heal. H. pylori is the cause of most ulcers. And this is interesting because for decades, doctors had thought that people got ulcers from stress. And when I say ulcers, I'm talking about your stomach or intestinal ulcers, that people got ulcers from stress and spicy food, from smoking or other lifestyle habits. But in the early 1980s, H. pylori was discovered, and it was found that this was the bacteria that was causing the majority of stomach and upper intestinal ulcers. Specifically, H. pylori infection is found in 95% of duodenal ulcers and 80 to 85% of gastric ulcers. So you should make note then that it is more commonly the cause of duodenal ulcers, remembering that the duodenum is the first part of the small intestine, so sometimes described as the upper part of the small intestine. H. pylori increases the risk of developing gastric cancer, as mentioned. More specifically, though, it's called a gastric adenocarcinoma. Remember that carcinoma refers to cancer that forms in epithelial tissue. And when we talk about the epithelial tissue of the stomach that contains glands, we call it adenocarcinoma. So we can say then that an adenocarcinoma is cancer of glandular tissue, and then gastric we know refers to the stomach. H. pylori is also linked to the development of gastric lymphomas, specifically MALT lymphoma. MALT stands for mucus-associated lymphoid tissue. Now, as I already informed you, H. pylori can cause a persistent asymptomatic infection in many people, so you can have it and not know it. And then others are not so fortunate. But in any case, H. pylori works by attaching itself to the gastric, so the stomach, or duodenal, the upper intestinal tract, epithelial tissue, and it triggers an immune response. And like we know with any immune response, we're going to get recruitment of immune cells, such as macrophages, neutrophils, lymphocytes. This can lead to the release of inflammatory cytokines, which in some cases can start to promote cellular injury. And once we have cellular injury, we're probably going to start having symptoms. Now, in addition to what I just spoke of, lymphocytes, so still part of the immune response, are going to start producing autoantibodies. Autoantibodies implies that it's going to be attacking ourself. So we end up attacking our own gastric or duodenal epithelial tissue, causing cells to become injured. Remember, specifically the mucosal cells. And when this is occurring, obviously there are going to be some degree of symptoms, whether it's symptoms from inflammation or symptoms from ulcers. H. pylori is more common in certain areas of the world than others, and that's because of sanitation practices and access to clean water. With good health habits, you can protect yourself and those around you from H. pylori. Simply not washing your hands after using the bathroom can increase the risk that you will infect yourself, or say not washing your hands before consuming food, then you are increasing the risk that H. pylori can enter your body. And as I've already mentioned, a lot of people can fight off the infection. Some people it will be kept at bay, whereas others will develop symptoms which can lead to a worse prognosis if it's not treated successfully. So that was talking specifically about H. pylori because it is such a big problem and such a common cause of gastritis and ulcers, as well as potentially cancer. But let's talk a little bit more about gastritis more generally instead of just focusing on H. pylori. And we're going to look at the differences between two different states, acute gastritis and chronic gastritis. First of all, what's the difference between acute versus chronic? Acute, which is more common, when we say acute, it is usually something that comes on more suddenly and oftentimes more localized, whereas chronic is something that persists for a much longer period of time, and oftentimes because it's been around for a while and a problem for a while for that person, it's usually more diffuse throughout the stomach rather than localized to a particular area of the stomach. So we know that gastritis is caused by injury to that protective mucosal barrier. And we've talked about H. pylori being a cause, but some additional causes of acute gastritis include the use of NSAIDs, so that stands for non-steroidal anti-inflammatory drugs, alcohol and other drugs, and acute stress. I'm going to speak for a moment, though, about NSAIDs. Let's say you're having a headache or you have pain in your body and you choose to take Advil or ibuprofen, which is an NSAID. What that NSAID will do, hopefully, is help with your pain. And one of the things that causes pain in our body is called prostaglandins. And we've talked about them before. You've learned a little bit about them in other courses, but prostaglandins will have a number of effects on your body, including causing pain. And so when you take an NSAID, what it's going to do is block the action of what's called COX-1 or cyclooxygenase 1. And what this will then do is prevent the formation of more prostaglandins, thereby reducing your pain. But here's the problem. In doing so, we lose a benefit of prostaglandins, which is stimulating the secretion of mucus. And so we've killed our pain, possibly, but now we've also reduced the amount of stomach mucus or gastric mucus that's formed that protects our mucosal lining. And so people that take NSAIDs a lot are more likely to develop inflammation and ulcers of the stomach or digestive tract. Chronic gastritis, more common in the elderly, also has a common cause of H. pylori, but people that are experiencing chronic stress, just the normal process of aging, which changes how our cells function. So if many of the cells in the stomach are aging and not functioning well, then you could probably see why it would cause more diffuse gastritis. And also a condition called chronic bile reflux. What happens with chronic bile reflux is that when bile refluxes from the small intestine into the stomach, it causes irritation and inflammation. So what does that mean? Well, the stomach is cut off here in this image, but normally bile would leave the gallbladder and empty into the small intestine, hopefully moving in a one-way direction throughout the rest of the digestive tract. But what happens instead with bile reflux is it moves up and ends up in the stomach. And the stomach is not designed to be exposed to bile, especially on a chronic basis. And so it can cause irritation and inflammation, leading to a diagnosis potentially of chronic gastritis. We're going to look a bit closer at some of the effects specifically of chronic gastritis. And that includes mucosal atrophy, so that's atrophy of the mucosal epithelial tissue. Ulcer formation, more appropriately called a peptic ulcer, and we'll talk about peptic ulcer disease on the next slide. Pernicious anemia, and intestinal metaplasia. When inflammation of the stomach lining becomes chronic, mucosal atrophy is known to occur. And so this is where we're getting thinning of that mucosal layer, and loss of this protective layer can then lead to ulcer formations. So thinning of this mucus epithelial tissue means that the cells can no longer produce the same quantity of mucus that they usually do, which means we lose that protective barrier. The acidic nature of our stomach starts digesting that stomach layer, which can lead to painful sores or peptic ulcers. So peptic ulcers, we know then, are due to the disruption of that normal mucosal barrier, oftentimes occurring when somebody's experiencing chronic inflammation rather than acute inflammation of the stomach. And if the ulcerations continue to worsen, so an ulceration being this wound that forms in the lining of really any epithelial tissue, if it continues to erode deeper and deeper, it could eventually cause perforation. And this is really a hole in your stomach where now the stomach contents can leak out into your abdominal cavity, causing inflammation of the abdomen, a condition called peritonitis. This is inflammation of the peritoneum. Chronic inflammation can also lead to pernicious anemia because remember, we have cells within that mucosal layer, the parietal cells, that make intrinsic factor. And if the parietal cells are not functioning the way that they should because they've been irritated or damaged to some degree, then we can't properly facilitate B12 absorption. And B12 is required for the development of red blood cells. So reduced red blood cell production, in particular reduced production of normal red blood cells, it can lead to what's called pernicious anemia. And metaplasia. Remember, metaplasia is a change in cell type. So we're changing cells from the normal stomach cells to a different cell type to better withstand the environment, as we know occurs when a cell needs to adapt to a different environment. So what happens is intestinal metaplasia. This is where your stomach cells, your gastric cells, start to resemble intestinal cells. And these intestinal cells, this new cell type, doesn't have the same secretory function, the same ability to produce mucus, among other things, as the original gastric cells do. And we also know that over time, metaplasia could potentially, these constant changes, could lead to further changes that predispose somebody to the development of cancer, stomach cancer. So intestinal metaplasia then is really considered to be a pre-cancerous condition. But remember that with cellular adaptation, we could see reversal back to the normal state, providing that that inducing stimulus is removed, whatever it is that's causing that inflammation. You can see a simple diagram here showing you inflammation of that mucosal layer. Remember, that mucosal layer contains so many different cells that produce different substances that are required for normal function of the stomach. This is showing you an atrophied layer, mucosal layer, and this is showing you intestinal metaplasia, different cells designed to withstand that adverse environment. Peptic ulcer disease is ulcers that form in the upper gastrointestinal tract. So when we talk about peptic ulcer disease, it could be the lower esophagus, the stomach, or the duodenum. In any case, though, these ulcers that form are really just breaks in that mucosal lining. They can be classified as being acute or chronic, and superficial or deep. Superficial erosions, or superficial ulcers, also known as erosions, are really just where we have that mucosal layer eroded away, but it doesn't penetrate beneath that. Remember that muscularis mucosa that we have? Now, deep or true ulcers are going to penetrate or extend through that muscularis mucosa, maybe even further into the submucosa and down into the tunica muscularis muscle. And if it continues to go further down, it could penetrate right through, causing a perforation. So to orient yourself, this is the lumen. This is where food would be present, as well as up here. Because with true ulcers, the blood vessels are going to be damaged, this can cause hemorrhaging as well, or bleeding. Still on the topic of ulcers, but focusing on gastric or stomach ulcers, we know that they can be associated with gastritis. So somebody with inflammation of the stomach over time, it could lead to the development of an ulcer. The most common location of a gastric ulcer is at the gastric antrum, also known as the prepyloric antrum. So if we look here at this image, this region right here is considered the pyloric antrum. It's really the initial portion before we get to the pylorus here, or it's the initial portion of the pylorus, but it's near the bottom of the stomach. Okay, just sort of proximal to that pyloric sphincter that we know separates the stomach from the small intestine. So when somebody develops gastritis, we know that that is likely caused by H. pylori, but here are some other causes as well. And then over time, that mucosal layer becomes damaged. And that mucosal layer is here, which contains, just because it says mucosal layer doesn't mean it's just referring to mucus. Remember, the mucosal layer consists of a whole bunch of different gastric glands, the mucous neck cells being the one that produce mucus. And you can see that close proximity of these mucous neck cells that produce mucus, how close they are to the interior of the stomach. But in any case, when we have injury to this mucosal layer, we're going to have a reduction in the function of one or more of these cells, including the mucous neck cells that produce mucus that act like a barrier or a coat along the stomach lining. And reduction in the production of mucus is going to mean that the acidic nature of our stomach is going to become a problem. The acid or the hydrogen ions are going to now be able to penetrate through and into this stomach rather than that being prevented by that mucosal barrier. And as we start digesting the stomach, it can lead to gastric ulcerations. If these ulcerations become deep enough, we talked about those true ulcerations on the previous slide, what this can do, we know, is cause bleeding. And what bleeding will do is the blood will mix with digestive enzymes that are present within our stomach, and this will cause a couple of different potential effects. One is called melena. Melena is black, sticky, tarry, foul-smelling stool that's caused by the digestion of blood within your GI tract. So what happens is the blood that's produced by this ulceration is going to move through your digestive tract and be digested. And then it turns into this black stool that more appropriately is called melena. So this is very important for you to know. Another effect is hematemesis. This term here is usually relating to vomiting, and this refers to blood. So hematemesis is the vomiting of blood. However, because it's been mixed with digestive enzymes, the blood has a coffee ground appearance. So the person vomits up and it looks like coffee grounds. This is very different. The vomiting of blood is very different than the coughing up of blood, which would imply something to do with your respiratory tract. Hematochezia. Hematochezia this is different. This is referring to a lower intestinal bleed, whereas these two, relevant to this slide, are an upper intestinal bleed. Hematochezia is where somebody will have a bowel movement and they will see fresh red blood within the toilet. And that implies that there's some lower gastrointestinal bleed. And the reason it's bright in color is because it hasn't been digested. Since digestion, for the most part, especially with digestive enzymes, occurs in our upper digestive tract. Let's move on to speaking more about gastric or stomach cancer, which we know can result from intestinal metaplasia, a precancerous state, as well as chronic ulcers. In areas such as East Asia, as you can see from this graph, rates of stomach cancer have remained quite high, but have declined in North America. And the reason for that is, for these geographical differences, is related to a few different things, including food consumption. So in terms of exposure to carcinogens, which we know are substances that can cause cancer, and the exposure to preservatives. So food has a huge involvement, and we're not exempt from that even here. It's just that in certain areas of the world it is a bit higher. And we know H. pylori is an issue as well, and that has to do a lot with sanitation, where we see those geographical differences, and the availability of clean water. Cancer is considered a silent killer because many of the symptoms that come with stomach cancer can be overlooked by individuals, but also by doctors. Endoscopic visualization and usually a biopsy is needed to establish a diagnosis of gastric cancer. Endoscopies is a non-surgical procedure that's used to examine a person's digestive tract. So they can use what's called an endoscope, this flexible tube with a light and camera attached to it, and it goes into your mouth and down your esophagus and continues on in order to properly examine your upper digestive tract. So it gives a bit of an image and also the ability to take a clear biopsy. The majority of gastric cancers, as I've already mentioned, are adenocarcinomas. And to tell you again, an adenocarcinoma is a type of cancer that is produced within the epithelial cells of the stomach, but the glandular cells more specifically. This diagram at the top here shows you some of the more common locations where gastric cancer will pop up. But what is clear is that the majority is in this region here. So we can say that about 50% are going to develop in that what's called the pre-pyloric. Here's the pyloric region. Here's the antrum. So the pre-pyloric region here. And only about 10 to 15% of gastric cancers are actually familial, so something that you inherit, meaning that there is a lot you can do in terms of your own lifestyle choices to help really reduce your odds of developing stomach cancer. And once again, remember that when you have gastritis or intestinal metaplasia, and certainly the formation of ulcers that can occur, they are strongly linked to the development of gastric cancer. We're moving on to talking now about duodenal ulcers, so the first part of our small intestine. Remember that peptic ulcers are sores that develop in the lining of three main locations. I said the lower esophagus. We talked about the stomach, and they can also occur in the small intestine, more specifically, more commonly in the upper parts of the duodenal area. I'd like you to make note that duodenal ulcers occur with greater frequency than other types of peptic ulcers, such as those in the stomach and the esophagus. Some developmental factors that we've really already spoken to include H. pylori, so that's the big one, the use of NSAIDs and other medications, hypersecretion of stomach acid and pepsin, which are both problematic for the stomach lining. So even if we're producing the normal amount of mucus, if we're producing too much substances that are aggressive towards the stomach, then that mucus barrier might not be enough. Cigarette smoking also increases the risk, and the reason for that is actually similar to the reason that NSAIDs can cause ulcers. It's because cigarette smoking reduces the production of prostaglandins, which we know work to maintain gastric mucus production. Also, people that smoke have a higher incidence of H. pylori infection. Now, duodenal ulcers are not usually associated with gastritis. So even though the stomach and the duodenum are very close in proximity to one another, if the stomach is inflamed, it is unlikely to cause an ulcer to form in the duodenum. But we know that if the stomach is inflamed, it can cause an ulcer to develop, or multiple ulcers to develop in the stomach. Another thing that we spoke about when we talked about H. pylori and how if it causes an ulcer within the stomach, it could lead to the development of cancer, stomach cancer. So then the question is, if we have, let's say, H. pylori that ends up causing an ulcer in the duodenum, and this persists, is it likely to cause cancer? And the answer is no. And the reason for this is not well understood. But what we do know is that cancer risk is not increased with duodenal ulcers, but it is with gastric ulcers. Now let's look at clinical manifestations. So remember, that's the signs, symptoms, or evidence that some sort of disease or condition exists. Intermittent epigastric pain, acute bleeding, and perforation can all be seen with both gastric and duodenal ulcers. Epigastric pain is pain in the upper abdomen area, which is where your stomach is located. And of course, the perforation is a much more serious state and more unlikely than these states. And part of the reason for that is because if somebody does have enough pain and they are bleeding, then it's evident that there is an ulcer, so there'll be some medical intervention done to prevent that ulceration from leading to a perforation. But what really is important to identify with duodenal ulcers is that they can mimic cancer, in particular because of the way that they look. This here is an example of what's called a kissing ulcer from overuse of NSAIDs. So what we have is, this is the duodenal wall. We have these ulcers that are found on opposite walls, and when there's movement of the intestinal tract, it can look like these ulcers come together and kiss, so they're called kissing ulcers. So the symptoms of gastric ulcers and duodenal ulcers can be quite similar, in particular with the common pain that is felt in the epigastric region that's sort of intermittent. But a big difference to make note of is when the pain occurs. Pain from a gastric or stomach ulcer oftentimes occurs when the food is still in the stomach, so shortly after eating. Whereas pain from a duodenal ulcer is more likely to occur when the stomach would be empty, which, depending on what you're eating and the person, can be anywhere from 20 minutes to 2 hours after eating. And so asking a patient to pay attention to when it is that they experience their pain can be valuable information clinically. I'm going to now speak about stress ulcers, also known as stress-related mucosal disease. A stress ulcer is an acute form of a peptic ulcer, so very seldomly do they become chronic. And these ulcers tend to accompany the physiologic stress of severe illness or multi-system organ failure or some sort of major traumatic event. It could be that somebody had a severe burn or a head injury, for example. And usually what we see is multiple ulcers rather than just one. And they can affect the stomach as well as or the duodenum. Stress ulcers can be classified as ischemic ulcers or Cushing ulcers. So I'm not referring to your everyday stressful events or just a compilation of multiple days of stressful events. We're talking about severe states. With ischemic ulcers, they are going to develop within hours of some sort of event. So somebody may have hemorrhaged. Maybe they had multiple systems within their body that are traumatized. Severe burns, heart failure, or sepsis. And in these events, what we will see is that there's going to be ischemia to the stomach and or duodenal mucosa, leading to ulceration. Cushing ulcers are stress ulcers that are associated with severe head trauma or brain surgery. And when somebody has a traumatic event to their brain, one of the effects that can be seen is an increase in vagal nerve stimulation. The vagus nerve is a cranial nerve that has many different functions in the body, including regulating digestive function. And if the vagal nerve becomes overstimulated, what we see is a reduction in mucosal blood flow and a hypersecretion of acid. And that is going to be a very poor combination for mucosal health, as you know. And remember that it's likely that there'll be multiple ulcerations seen, not just one. We're going to move on to the topic now of inflammatory bowel diseases. Please make sure you're aware that this is very different than irritable bowel diseases or irritable bowel syndrome. The two types we're going to look at are Crohn's disease and ulcerative colitis, and we're going to start by comparing the two. First, we'll look at the locations that are affected by these conditions. With Crohn's disease could affect anywhere in the gastrointestinal tract, anywhere from the mouth all the way down to the anus. It's also common with Crohn's disease to see what are called segmental or skip effects or skip lesions. These are where some segments of the digestive tract can be affected and not others, almost like it's skipping certain areas of the digestive tract. With Crohn's disease, you can also have one side of the intestinal wall that's affected, and then the other side, just adjacent to it, is not. But when we look at ulcerative colitis, this is going to be specifically affecting the colorectal region, and that's sort of in the name, the COL component, the colon. So only the colorectal region. And it doesn't have the skip effects. Instead, it's continuous. And we'll see an image of these on the next slide. In terms of causative factors, both Crohn's disease and ulcerative colitis have idiopathic causes, so no known cause. They're both considered autoimmune, so the body is attacking itself. With Crohn's disease, though, there is a strong family history, whereas a family history, what we would call familial, is less common with ulcerative colitis. But additional causes of ulcerative colitis can include dietary causes. I'm even myself seeing so many more people that have ulcerative colitis, and I do believe there is an even stronger dietary component than ever thought before. Certain infectious diseases are thought to maybe cause ulcerative colitis, and then there are genetic, so alterations to genes and potential immunological factors as well. Chronic inflammation is seen with Crohn's disease, and the inflammatory process begins by spreading through the entire intestinal wall, so through the layers, so what we say transmural. And then if the disease progresses, it can lead to neutrophil infiltration into parts of the intestines, resulting in abscess formation and ulcers. But with ulcerative colitis, and this is important, it's only the mucosal layer that's affected. And so what we'll see are more superficial ulcers typically. And you'll see on the next slide that the ulcers seen with ulcerative colitis form what's called pseudopolyps, and we'll have a look at how these appear, but ultimately what they mean is that it looks like there's polyps, but they're not actually polyps. But we'll come back to that. Common clinical manifestations of both conditions consistently include recurrent diarrhea and abdominal pain. Features that are specific to Crohn's disease could include a granuloma formation. A granuloma is a small area of inflamed tissue, and anal and perianal fistulas, an abnormal connection, both of which could lead to an obstruction. Granulomas can actually get large enough that they can appear as this abdominal mass. Malabsorption within the small intestine can be evident with nutrients like B12, for example, not being absorbed properly, leading to pernicious anemia. We can also see the malabsorption of fat, and if we're not absorbing fat properly, that it ends up becoming a part of our stool. And what can be seen is what's called steatorrhea, which is the presence of excess fat in the stool. So the stools can almost be floating in the toilet water and take on a pale appearance. And then weight loss is common due to malabsorption. Whereas with ulcerative colitis, bloody stools are common, and that's due to the presence of the ulcers, which are in the very much distal part of the colon and the rectum. So we would have more of a fresh blood appearance, hematochezia, versus a digested blood appearance. And even ulcers that are superficial can bleed, but it's once they become much deeper, like what can occur with perforations and other conditions that I've spoken of before, that you could have hemorrhaging occur. But superficial ulcers do still bleed, and people with ulcerative colitis do have an increased risk of developing cancer. This image here shows you some of the differences that we've talked about with Crohn's disease and ulcerative colitis in terms of how they would appear. So remember, with Crohn's disease, we have those segmental lesions that can really occur anywhere in the GI tract from the mouth to the anus. Whereas with ulcerative colitis, we know it is going to be continuous rather than skipping areas, continuous and affecting the colorectal region. With Crohn's disease, we know that the inflammation is going to affect all layers, so transmural. Whereas with ulcerative colitis, what we have is just the mucosal layer that is affected. So we're only going to be getting superficial ulcerations. And I mentioned the term pseudopolyp earlier. A polyp is an abnormal growth, and when polyps exist within the colon, they look like just sort of little balloons that hang off the intestinal wall into the lumen. And a pseudopolyp is something that looks like it's a polyp or an abnormal growth, but it's not. The reason it looks that way is because here we have this healthy tissue or normal tissue, and then in between is the eroded area, giving the appearance of a polyp. Moving on now to a different topic, which is GI tract obstruction. And an obstruction is going to be really anything that blocks or prevents the normal flow of food throughout the digestive tract. And although an obstruction can occur anywhere along the digestive tract, we're going to be looking at a few specific examples. Starting with pyloric stenosis and pyloric obstruction. Stenosis means narrowing, and an obstruction would imply, in this case, some physical obstruction. So with pyloric obstruction or stenosis, we have either narrowing or blocking between the opening of the stomach here and the duodenum. And it can either be acquired, so it develops at some point throughout the person's life, or congenital, meaning that they were born with it. And when they're born with it, so I'll just draw an arrow here that we're talking about congenital. When they're born with it, what they're born with is hypertrophy or enlargement of the sphincter muscles here. And they become so thick and really tight that it prevents the proper movement of food or chyme through into the duodenum, and it can lead to vomiting and then malnourishment. So now looking at acquired, which we're going to look at here. Acquired is usually caused by a duodenal ulcer that has so much inflammation present that in itself acts as a physical obstruction. And so an ulceration, say here, could cause so much inflammation that it becomes more difficult for the stomach to move chyme through that pyloric sphincter and into the duodenum. So it acts as a bit of a blockage. And then similarly, carcinoma, if there is a cancer somewhere around here, it can also act as a physical barrier. Clinical manifestations can include a feeling of fullness because of not being able to properly empty the stomach. Nausea and vomiting can accompany that, and you can get distension of your stomach because of inappropriate emptying. The stomach also will try to work really hard to push past the obstruction, and in some cases it's successful, and once food can move past that obstruction, then the person will get some relief. So that was really the pyloric region affecting the duodenum. We're going to be looking a little bit more distally or further down the digestive tract now at different types of intestinal obstructions that can exist. And this can be caused by any condition that prevents the normal flow of chyme through the intestinal lumen, or a failure of normal intestinal motility, that normal peristaltic movement, in the absence of an actual physical obstruction. There are four main types of intestinal obstruction listed here: hernia, intussusception, constriction, adhesions, and volvulus, and we're going to match them to their appropriate definition. A hernia is an outpouching of the small bowel or the small intestine where it moves from where it's supposed to be. So it could be under higher pressure, moving out into an area where it's under lower pressure. And as you can see here, this would inevitably cause an obstruction because food is going to have a more difficult time moving through. Intussusception is the telescoping or invagination of one part of an intestine into another. So we can see that occurring here. And now we have a narrowed lumen for food to move through, and also the potential of food to get stuck where the intussusception has occurred. Constriction adhesions. These are usually secondary to abdominal surgery. So somebody can have surgery for something, and there's an irritation after surgery that can lead to the formation of adhesions that end up causing an obstruction. So we can see an adhesion formed here, which it's like almost like you've had a piece of tape that's connected two areas, and it can prevent the normal movement of food through the intestinal tract. And then in our fourth example, we have a volvulus. A volvulus is the formation of knots or twists that can occur that naturally will lead to an obstruction, physically blocking food from being able to properly move through. Let's look at what could happen if there was not medical intervention when somebody had an intestinal obstruction. So if there was an intestinal obstruction, whatever the cause may be, it can lead to accumulation of gases and fluids proximal to the obstruction. So if the obstruction is, let's say, here, prior to that, in this direction, what we would see is the accumulation of gas and fluid that's occurring here because food can't get past this point. This initially can lead to some distension, nausea and vomiting are usually triggered, colicky abdominal pain would likely occur. The person won't want to eat food, they're eating less food, so it leads to a reduction in nutrient absorption, and now their body starts using up their carbohydrate reserves because they're in a state, they get to the state of starvation. Complications arise due to loss of water and electrolytes within the body due to malabsorption. Dehydration will result along with electrolyte disturbances. For example, hypokalemia, which is low levels of potassium in the blood, and hypochloremia, which is low levels of chloride in the blood. And in both cases, many functions in the body can be affected when we have low levels of these ions. Chronic effects will be seen if pressure from the intestinal distension is severe enough where it can occlude or block arterial circulation, resulting in words you are hopefully now familiar with, such as ischemia, necrosis, in severe cases perforation, and peritonitis. And that's a big problem. Bacteria can also start to proliferate at the site of the obstruction, and if the bacteria proliferate enough, they can migrate or translocate across the intestinal wall where they can get into the blood and infect the blood, causing sepsis, so blood infection. And then this infected blood can travel to other organs of the body, causing organ failure. So you can see why it's important if somebody does have an obstruction to treat the cause quickly. We spoke about intussusception briefly when I defined it on an earlier slide. We're going to talk about a specific type called ileocolic intussusception. This is the most common cause of acquired intestinal obstructions in infants and children. so 80 to 90%. The ileum usually invaginates the cecum in this condition and also invaginates part of the ascending colon by collapsing through the ileocecal valve. So what does that mean? Well, here we can see where the cecum should be. Remember that the ileocecal valve is that valve that brings really food or fecal material from the ileum into the cecum, which is the first part of the large intestine. And so what's happening with this condition is the ileum, which is the last most distal part of the small intestine, invaginates both itself and the cecum into the ascending colon. So if we look here, it would be this part invaginates through that ileocecal valve and the cecum as well. They both invaginate up into the ascending colon. The cause, well, first of all, it's more commonly seen in males. It's considered idiopathic in a lot of cases, so randomly occurs with not a known reason why. It can occur as a result of a surgery, so after surgery, and it can be associated in some case with the presence of tumors, adhesions, which are just fibrous connections, and polyps. Clinical manifestations include the sudden appearance of abdominal pain, so these kids will be in severe pain with flexed knees. If it goes untreated, you'll start to see vomiting, bleeding, necrosis, and bowel perforation happening fairly quickly. In terms of treatment, surgery can be done if needed, but oftentimes a reduction procedure with water can correct the problem. So water can be forcefully injected through here to push the invagination back out where it's supposed to be. And on our final slide, we'll talk about Hirschsprung disease, also known as congenital aganglionic megacolon. To break this up, congenital means that you're born with it. Ganglion, this is part of our nervous system, so aganglion would be lack of, and megacolon is just a large colon. So with this condition, it's considered a very rare obstruction. It's a functional obstruction of the colon, so it's not a physical obstruction, and it's caused by the absence of the enteric ganglia, so enteric referring to intestines. So there's a length of the colon that is lacking its enteric ganglia. So it's not getting the normal innervation or nerve supply in order for the muscles to function. And so what will happen here with this neural stimulation is the muscle of the colon will fail to propel fecal material through the colon, leading to this functional obstruction. And so the proximal colon becomes distended and forms what's called a megacolon. So we can see here, this person was not born with ganglia along this length of the distal colon, and so it just doesn't really do a whole lot. And so everything proximal to that will back up and distend. And you could see how this works as more of a functional rather than a structural obstruction. But overall, this is considered rare, but this is one example of a motility issue rather than a physical obstruction. That's the end of today's lecture. Thanks so much for listening. I hope you enjoyed it. Bye for now.